All right, guys, week 7 wrap up. That's exciting. We're getting there. So today, or this week in lecture, we talked about the total body considerations. And like I said in the video, I hate that they talk about old people like they're all dying. Like, you have old people who have total knees that are still very active. And, I express that in the videos too, that we need to make sure that we're treating the patient, not the diagnosis. Yes, some total knees just need to be able to walk. Others need to be able to go out and play tennis or run up and down a basketball court because they're still refereeing. So just make sure that you treat the patient just like you would an athlete and get them back to what they need to do. Going over the research articles, the first one I'm going to talk about is the benefit of the rehab within 24 hours. I already knew the answer to this, but it's still nice to have a little bit of meat on your bones. And even so, this article's a little bit old. It's 9 years old, and it was interesting because the hospital stays were still like crazy long, when now, like we mentioned, we're doing total knees on an outpatient basis. The early mobilization, oh man, there's a fly, has been shown to decrease the complications such as DVTs, pulmonary embolism, chest infection, urinary retention, and an earlier discharge can be expected. I thought it was also interesting too that oh no, that's the other article, sorry. I'm getting my two total knees mixed up. When I looked at the articles, the exercises in this article, though, I was a little bit surprised. Like, they didn't do anything on the first day. But I don't know if that's like a day of surgery. Sometimes it might be. Like I mentioned, when I was doing a clinical rotation at a hospital in Galesburg, Illinois, we got the patients up same day. If they were a morning surgery, we got them up in the afternoon and walked them. Not a lot, like just got them up, walked them around in the room. But by day 2, what they did there is they had group therapy for all the totals, and they would walk them down the hall as far as they could for their group therapy. So they had a slightly less hospital stay was less. They showed improvements in the pain scale. They showed improvements in range of motion. Basically in everything, they had great improvements. One thing I did note, if you look at the table 2 up on this one, when it shows the pre-op range of motion, like 55 degrees, that's terrible. Terrible. But yeah, that one was pretty cut and dry. The earlier you can start therapy on a post-op total, the better. Total knee from that one. Let's go ahead and do the other one with the total knee, just so we're staying on the same page. The results on this weren't quite as fantastic as I like them. I am a neuroscience junkie. Like, a pain neuroscience just fascinates me, and I think it is a huge area that our field can use improvements in that we educate patients on what's wrong with them as far as a biomechanical or anatomical aspect, but we don't do a great job of explaining pain. Letting them understand that pain's an output, not an input. So again, that's part of the reason I chose this one, is because I just like it. So basically what they did is they gave him a video beforehand and had him watch it, and they were kind of, explaining the pain, post-op rehab, post-op physical abilities, and basically just kind of what to expect. One thing they did do too that does go beyond the video is they did a skills teaching session, which I think is kind of cheating because that includes a little bit more than just the video. But anyways, the thing I was super interested in was that, yes, it did decrease it for 2 days post-op, which is important because I have people come in to my clinic, 2 days post-op. So if I can have them less pain on that second day, if they, just have that education, like, it's so easy to implement education. Like, it's not like we're trying to use some med or anything like that. Like, it's just educating the patient. So if I can have them in less pain when they come see me on day 1, like, great, because day 1, or when they come see me, which is day 2 post-op, day 1 for rehab, some of them I'm like, oh my gosh, just don't pass out because they're still in so much pain. But I did find it interesting that the control group, or the experimental group, they had a higher score on the muscle power, and they were more compliant with straight leg raises. Straight leg raises are very hard. For example, I will get patients that do home health come to me 2 weeks out and still struggle with a straight leg raise. But I thought that was pretty interesting. Again, I think more research could be done on this. Still positive in that 2 days out, they had less pain with just the education. So I think that's so easy. And then lastly, the patellar tendinopathy. I threw this one in there because it is so common. I was so surprised when I read it that, well, that one of the articles had a mean age of 67 years old. Like, what the heck? I don't think of patellofemoral pain being, patellar tendinopathy being an older person's pathology. I think of it being a young person's. Because we think of it decreasing, but then they're saying, well, now we're not for sure. But the fact that in the majority of the studies, the patients were men. I think of this as more of a female dominant pathology. So that was just super interesting to me. And one rationale they had for that was because the extent that the power that the men can generate with through the quadriceps. So it was pretty interesting. So some of the intrinsic factors, a lot of these we've talked about, the muscle flexibility, lack thereof, especially of the IT band, the quads and the hamstrings, because the IT band can cause that lateral movement of the patella, and the quads and hamstrings, it can intensify the strain on the patellar tendon. The muscle strength, a lot of times they see the vastus medialis and the quads muscle have atrophied with the patellofemoral pain. If you didn't do this article, I would recommend, looking at these tables because it's showing you what some of the causative factors are. And like for the first one, it's males greater than females. A couple of them, it's just mind-blowing to me. Because like I said, we think of it as a female pathology. I think of it as female pathology. So also it has to do with the training hours that we know. Interesting, the type of sport. One study said that volleyball players were more susceptible than basketball players. I thought that was pretty interesting. Training on the hard surfaces is going to increase it. Of course, eccentrics. Eccentrics are the way to train it. They have superior results. They're also finding some positive results with electric shockwave therapy, which is interesting. Return to sport just varies greatly. Some of them say you can go back when you have pain as long as it's not greater than 3 out of 10. Others say no, you have to wait till it's pain-free, which could be up to 12 weeks. Like, that's a long time. Obviously, we need to correct mechanics. So with the intrinsic factors, the most two prominent were flexibility and strength, and evidence for other factors was kind of indecisive. A lot of these things we can fix, so we should be happy about that. But again, on the eccentrics training, it showed exceptional results within 10 of the 13 articles on rehab for patellar tendinopathy, reporting positive results. Their perception is still that eccentric training is the gold standard, conservative treatment modality, and superior to other treatment options based on its excellent and sturdy outcomes. It not only assists with diminishing of neurovascularity, but also facilitates improvements in neuromuscular activation, improved muscle strength, and muscle endurance. So they recommend doing it on a single leg squat on a decline. It had superior results over one that's performed on a flat step, and the patients need to be performing it frequently throughout the day, once or twice daily, 5 to 7 days a week. Again, the positive results with the electric shock wave. There's some positive results with deep friction massage and static stretches. Obviously then, correcting the faulty mechanics so that we decrease the load on the tendon. Longevity, 6 weeks for up to 12 weeks. But yeah, I thought that one was interesting because there were some factors in there that I did not expect. So that's fun thing about research is you get to learn new stuff. All right, so nice job. I like the discussion boards again this week. Like I said, it's getting a little bit more into my wheelhouse of what I see every day. So I feel like I can I can add a little more input. But now we're moving on. Next week is spine and pelvis, and then we move on to upper, and then we move on to lower. So that makes me happy because that's what I enjoy. Hope you have a great week. Hope you enjoy your day. And as always, let me know if you have any questions. Thanks, guys.